Hello and welcome to this presentation on rational deprescribing. Now, the psychiatrists have an important role to help the team, especially the primary care team, identify potentially inappropriate medications, especially in the elderly, educate the team regarding why these are inappropriate, such as they have high anticholinergic properties, suggest use of non-pharmacological interventions in place of potentially inappropriate prescriptions for, say, anxiety management, depression management, psychosis management, especially in people with dementia. And then again, suggest safer medication alternatives, either prescription or over the counter, if available, to replace the potentially inappropriate medications. And when non-pharmacological interventions are not feasible, many times we can replace safer antidepressants from older, more risky antidepressants, for example. The key potential benefits of rational deprescribing are many: improved quality of life, improved cognitive function, reduced risk of delirium, reduced risk of falls, and so on. Rational prescribing needs to be done in an interdisciplinary setting where the psychiatrist works closely with primary care providers, the patient, the consultant pharmacist, even the family members, nurses, social workers. And we have to approach it systematically. There are 6 steps where first we ascertain which medicines are most risky, then decide what's the plan of reducing these medicines, and then implement the plan and then monitor the response. There are many criteria for potentially inappropriate prescriptions, especially in the elderly. We give medicine sometimes without evidence for their benefits for a specific condition. Sometimes we give medicines that do not conform to standard of care. Sometimes we give medicines that do not conform to clinical practice guidelines, and so on. 2 key examples in psychiatry, especially in the elderly, are antipsychotic use and benzodiazepine use. I strongly believe that both these medicines can cause serious problems, and we can easily reduce the use of these medicines with comprehensive collaborative care and non-pharmacological interventions. The criteria that we use in the United States are the Beers criteria for drugs that are inappropriate in the elderly. In Europe and other countries, they have stop criteria and start criteria. Each of them are excellent tools. Other criteria that I use in consultation with consultant pharmacists, especially in nursing homes, is to monitor anticholinergic burden of all the prescribed medicines, the prolongation of QTC interval on the cardiogram so that we can monitor risk for arrhythmias and sudden cardiac death, renal dosing because chronic kidney disease is common, drug-drug interactions are common, adjusting medicines for liver diseases, and now we have started to do some pharmacogenomic testing. This case shows that some of the elderly people, if not many, are on so many medicines. And what would be an example of rational deprescribing? In this case, I recommended to reduce and discontinue buspirone because the person did not have an appropriate indication, such as generalized anxiety disorder. We slowly tapered and discontinued opioids for chronic non-cancer pain management. And we started doing very comprehensive Atman approach that I've described in another presentation to manage chronic non-cancer pain without opioids. In this case, glimepiride was discontinued because the hemoglobin A1C was 7.4. And in the nursing home population, you might need to have much higher hemoglobin A1C to start giving anti-diabetes medicines. Clonidine was tapered and discontinued because this person had low blood pressure, and clonidine would actually worsen the low blood pressure and cause serious problems. After 3 months of follow-up with rational deprescribing, this patient's depression improved, pain improved, cognition improved, there were no falls. Can't get better than this. Atul Gawande, in his excellent book, Being Mortal, has told us, we are caught in a transitional phase. However miserable the old system has been, we are all experts at it. We know the dance moves. with this new way in which we together try to figure out how to face mortality and preserve the fiber of a meaningful life with its loyalties and individuality, we are plodding novices. We are going through a societal learning curve one person at a time. We are experts at prescribing, and we are plodding novices in rational deprescribing. But let's learn this and keep going. The three key references are our own textbook by Dr. George Grossberg and myself, Psychiatric Consultation in Long-Term Care. We have an entire chapter on rational deprescribing, and then these two references. I hope this has been useful for you. Take care. Namaste.